Hello, and welcome to another one of our presentations on mental health. Today we wanted to talk about common mental health disorders and review a few of the disorders that we have seen over our time of working with high school students. My name is Lauren Albert, and I am one of the licensed professional counselors for the district, and I work at Brazosport High School. We will also be joined today by Paige Potts and Sarah Eddy, who are licensed counselors that work at Brazoswood High School. Today, we wanted to talk about some of the disorders that we have noticed as we work with our high school students. In order to be a diagnosis, it has to meet criteria in the DSM-5, which is the book pictured below. And there's specific criteria for each disorder. Today, we're going to focus on anxiety, depression, adjustment disorder, bipolar, trauma, and some PTSD, and then substance use. We want to talk about the criteria used to have the diagnosis, some signs and symptoms, and then kind of what it looks like maybe with the teenagers that we work with. To start off with, we were going to talk about anxiety disorder. It is very common and it is very treatable, and it's something that a lot of people usually recognize some signs and symptoms with anxiety. It looks like excessive fear. It can be real or perceived. I don't have to agree that a student feels that way about a certain situation, but if they feel fear, then we need to work on that. Anxiety is an anticipation of future events. So it's not necessarily stress of something that has already happened or what they're currently going through, but they may be worried about something that's coming up in the future. Symptoms are beyond developmentally appropriate timelines, and they can have an impact on physical or present in physical ailments. So a lot of times I'll see students who have headaches or stomach aches or the sore throat, and the nurse doesn't see any reason for those. And then as we talk, we may notice some anxiety-provoking situations that create this feeling for them. The earlier the treatment starts, the better. Counseling can help, medication can help, coping skills can help. There's a lot of different ways that we can help students work through the anxiety. It does not have to stay around for their entire life. There are ways that they can work through the excessive thoughts or the fearful thoughts that they may be having, and ways to use some thought challenging techniques. Again, we just want to reiterate that it's very common. 1 in 3 of all adolescents ages 13 to 18 can experience an anxiety disorder. And as you can see, there are several different types of disorders that are listed under anxiety. There's separation anxiety, there can be specific phobias, social anxiety, agoraphobia, generalized anxiety, panic disorder, just to name a few of them that we have seen through our offices. Today, I just wanted to focus on generalized anxiety and kind of go over what the criteria is in order to have this as a diagnosis. First, it has to have at least 3 of the following symptoms: the restlessness or feeling on edge constantly, easily fatigued, trouble concentrating, very irritable, a lot of tension in the muscles or some physical ailments again, and disruption in the sleep pattern. So they either sleep excessively or they're having trouble sleeping at all. In order to become a disorder under anxiety, though, these symptoms need to last for 6 months or longer, and more days than not. That needs to be excessive worry that they cannot necessarily control, and it's over a whole bunch of different things. It has to impact their daily life. It will impact how they interact at school, at home, in social community, with their peers, in different areas. It's not just one specific class that they're feeling anxious about in order to be generalized anxiety. And we need to rule out any other kind of issue that may be going on to ensure that it's not due to substances or medication, there's not some kind of medical condition happening, or another mental health disorder. As you can see, a lot of these things are also common with adolescents and growing up and just becoming a teenager and then moving into adulthood. And so there's a lot of times that we just have conversations and we just kind of want to see, how often do these things last? How often do they feel this way? What do they do? What helps? What doesn't help? And again, for generalized anxiety, it needs to be 6 months or longer. I also just wanted to point out that sometimes there may be things that cause worry or create excessive worry or fear that don't necessarily meet criteria for the anxiety disorder, but maybe just common things that students face. So this example talks about worrying about bills or a romantic breakup, if there's embarrassment, or uncomfortable, awkward situation, being nervous about a test or a project or presentation, um, anxiety or sadness or difficulty sleeping after a traumatic event. Those are very common, but again, if it doesn't last for 6 months or more, then it wouldn't fall under a diagnosis of generalized anxiety disorder. However, on the other side, the anxiety disorder is the constant or unsubstantiated worry that causes significant distress and interferes with daily life. So this goes beyond just, I'm worried about a math test, or I'm worried about this presentation for history. It creates a lot of interactions in their daily life in multiple areas other than just one specific thing. They avoid social situations for fear of being judged. So they just flat won't go, refuse to participate, and just kind of change what they're doing in those moments. Seemingly out of the blue panic attacks or preoccupation with fear of having another panic attack, irrational fear or avoidance of object or place, and recurring nightmares, flashbacks, or emotional numbing related to a traumatic event. So these are things that we want to work on and we can help them with. But again, I just kind of wanted to show the difference between maybe what is everyday or common issues and working on stress tolerance and emotional regulation versus something that would create a disorder. Another common disorder that we typically see working with adolescents is depression. And so a lot of people ask, well, where does this come from? How did it start? It's a great question. We don't really know all of the answers. So there is some research that talks about the brain chemistry and how the makeup of the brain will impact a student's emotional regulation and feeling and could create some symptoms of depression. It could be hormones with the surges and the changes in the growing and the developing that's happening at this stage, and it could create symptoms of depression. There could be a traumatic history or an event or something that occurred to them, and maybe we're approaching that anniversary or something that reminds them of that time, and so there could be symptoms of depression. It could be something that they've learned that has helped them get by over time. And so these negative patterns of behavior, negative thoughts, and this feelings of sadness may have helped them. And so they feel like this is what they have to do. It could be a whole number of things, could be a combination of those things, but we're not 100% sure of like, this is the one cause. We just wanted to kind of show that it could be a variety of things, but there is hope and there is help, and we can work with students who may have symptoms of depression. Again, under the umbrella of depression, just like anxiety, there is multiple different diagnoses for depression. There's the major depressive disorder, seasonal affective disorder, which I feel like a lot of people have heard about, where in the wintertime, people may tend to get more depressed because of the light and the activity and the things happening outside. I would venture to say there's also some research that talks about in the heat of the summer, and when we have excessive heat waves, that it also creates some seasonal affective disorder. Persistent depressive disorder, premenstrual dysphoric disorder, and bipolar depression. So these are just some of the other types of depression and disorders that you may have heard about. Today, we're just going to talk about major depressive disorder. So when we talk about depression, what are we trying to look for? Well, according to the DSM-5, there has to be 5 or more of the following symptoms in a 2-week time period, and it has to represent a change for the person. And so again, these are going to be things that happen most of the day, nearly every day, for a 2-week time period that is not usual for how that person normally would operate or respond to situations. So loss of interest in activities. If they come to high school and they change their sport, that is not what we're talking about. If they decide that they want to do an art instead of a music class, that's not what we're talking about. Those are just growth and development and changes. But if they played baseball for 8 years and then now all of a sudden don't want anything to do with it, and they're not replacing that with another activity, that is something that we may want to just have a conversation about and kind of find out what is their train of thought on that. If there's a change in weight and it's not because of dieting and it's not just because of the adolescent development and the changes that typically occur during this time, but if they have a change in weight because of extra eating or not eating, if they're not trying to lose weight and they are, or if they've gained weight and they're not sure why, again, it's good to have a conversation and of course get that checked out from a medical doctor to ensure that medically they're okay as well. If there's a change in the sleep issues, sleep patterns, if they're sleeping way more, it's hard for them to wake up or stay awake, or if they're just not sleeping and only functioning on 2 to 3 hours of sleep. Again, we want to have those kind of conversations and find out what is happening and what may be triggering this for them. The restlessness or psychomotor agitation, the constant fidgeting, the moving, the not being able to sit still, the kind of uncomfortableness in their body, but like they can't control it. That's something that we want to also kind of look at as well. Fatigue, lack of energy, not being able to make it through the day when before that maybe they could, even if they're sleeping a lot, they still feel like they don't have energy. Those are things that we want to talk about. Feelings of worthlessness, helplessness, hopelessness. What's the point? What's the future? Those kind of conversations. Difficulty concentrating, can't make decisions, can't focus. They feel like they have the foggy brain. We want to kind of talk about that as well. Recurrent thoughts of death or suicidal ideation, even if there's not a plan, even if they just think maybe it would be better if I died, we want to have those conversations with them and look at depression as being a possibility for them. Again, it has to impair social, occupational, or other important areas of functioning. It's not due to substance use or medications. And we also want to take into account any recent grief or loss issues, changes or transitions in their life, major ones like moving, divorce, family dynamic changing, those kind of things, and then anniversary dates around those. It's very easy to confuse sadness with depression because some of the symptoms look the same. Sadness is just a natural emotional state. It's temporary. It's going to pass with time. Usually you can pinpoint kind of the trigger or the starting event or the reason that we're feeling sad in those moments. It does not significantly impair functioning in life. It may impact the day or two, just depending on the reasoning for sadness, but it's not necessarily going to impact for a 2-week time period or a lengthy amount of time in multiple areas of life. And it can often resolve on its own, and somebody can use their own coping skills and just kind of work through those moments of sadness. Depression, on the other hand, is a mental health disorder. It is diagnosed. It is persistent feelings of sadness, hopelessness, and worthlessness. There's possible many causes or triggers for it, and sometimes they just don't know what created it or why they started feeling the way that they feel. It does significantly impair functioning in multiple areas of life for more than a couple of days. Again, the diagnosing criteria is for at least a 2-week time period, but it's not just one day in one specific area of life. And it may require professional treatment. That's through medication, through conversation, through therapy, through coping skills, a whole bunch of different ways to help treat depression. But again, remember there's hope and there's healing and there are pathways forward. So that concludes anxiety and depression. And next up, we're going to hear from Ms. Potts about adjustment disorder and bipolar disorder.
Thank you, Ms. Albert. I'm Ms. Potts, and I am an LPC at Brazos Wood High School. So now we're going to switch over to another disorder. This disorder can kind of lay down the foundation for other disorders. It can manifest into disorders such as depression, anxiety, sleep disturbances. So we're going to be discussing adjustment disorders. Adjustment disorders are going to be disorders that are expressed through emotional or behavioral symptoms, and they're excessive or out of proportion to the life stressor or event that they're experiencing. What's indicative of a adjustment disorder is that it happens within 3 months of the onset of the life stressor or change. And it can cause impairments with social functioning, academic functioning, occupational functioning. There's going to be some sort of impairment with an area of functioning in their lives. It can also have different specifiers. So it could be presented with a depressed mood, with anxiety, with depressed mood and anxiety. It can also be presented with disturbance of conduct, disturbance of emotions, or disturbance of conduct and emotions. Some of the life stressors that may be the onset of an adjustment disorder are going to be situations that like the loss of a loved one or possibly moving and changing schools, again, change in academic setting, or there could be stressful events that the adolescent is experiencing, such as divorce of parents, breakups in relationships. or just relationships in general, chronic health problems, different academic pressures, legal problems, and then there could also be things like social isolation. They might even, an adjustment disorder might even be prompted by traumatic events like natural disasters, accidents, witnessing or experiencing violence as well. There could also be pre-existing mental health conditions or pre-existing stressors that make somebody more susceptible to developing an adjustment disorder. What's important to understand is that adjustment disorders can manifest into other disorders if they aren't addressed. Some different disorders that adjustment disorders can manifest into are depressive disorders, anxiety disorders. They may resort to substance use and develop a substance use disorder. There could also be somatic disorders. So these are going to be where it's presented through physical symptoms. So they could have chronic pain, headaches, stomach problems, things that we might not identify as a mental health issue. They may be presented through what we perceive as a medical issue. The next disorder that we're going to discuss is going to be bipolar disorders. So this is a disorder that a lot of people have heard of, but there's also a lot of misinformation about it. So we're going to break it down a little bit and discuss the different disorders within the bipolar disorder category. So bipolar disorder is going to be marked by significant mood swings. So these can be mania or hypomania, which we'll talk about the difference between those two in just a little bit, and depression. So these mood swings can affect things like sleep, energy levels, judgment, behavior, clear thinking. So the difference between mania and hypomania is going to be the severity of the elevated or irritable mood. So with mania, it's going to be more severe, and it's going to be seen in bipolar 1. So you might experience things like elevated mood or feeling euphoria. There could also be irritability. You're going to have increased energy, hyperactivity, restlessness, a decreased need for sleep. There could be racing thoughts, so jumping from one thought to the next, or difficulty focusing. Impulsivity, so engaging in risky behaviors like excessive spending or reckless driving. There can also be an inflated sense of self-importance or feelings of invincibility. And with mania in severe cases, it can lead to things like psychosis, so having hallucinations or delusions. Hypomania is going to be less severe. There's going to be milder symptoms. The person may seem like they're functioning, but it's still going to cause milder impairment with their daily functioning. Again, they may feel unusually energetic, unusually productive. They could be unusually irritable. And while mania is going to last for at least a week, it could last longer. Hypomania is going to last for about 4 consecutive days. And with both of these disorders, or with mania, hypomania, bipolar 1, bipolar 2, there's going to be a high risk for self-harm. So I listed a couple of different facts about bipolar disorder. There's a lot of different statistics. These are just the general ones. So bipolar disorder has a very strong genetic component. It could be triggered by things like childhood trauma. There's been a link to people that have been exposed to trauma for it having an earlier onset. The typical age of onset can really fluctuate. So it could be as early as adolescence or early teenagers, so 15, all the way to 30. But it can also develop in your childhood or later adulthood. It affects approximately, again, this is general, 2 to 3% of the population, and it affects men and women equally. Women may experience more frequent depressive episodes, and be more prone to rapid cycling, whereas men tend to experience more intense manic episodes and are at greater risk for risk-taking behavior. As I mentioned before, there are different types of bipolar disorder. There's going to be bipolar 1. Bipolar 1 is going to be marked by mania and depression. This is going to be more severe than the other types of bipolar disorder and can cause significant dysfunction in the person's daily life and task. So, as we discussed with mania, the different symptoms of mania, so elevated mood, elevated irritability. With bipolar 1, though, this can also lead to psychosis, which hallucinations, delusions, which could possibly lead to hospitalization. With bipolar 2, you are with mania, again, with bipolar 1, it's going to last for at least a week. It could be longer. The depressive symptoms are also going to last for an extended period of time, so a week or more. With bipolar 2, you're going to experience hypomania. So again, there's less severe symptoms, but still elevated sense of self, not needing as much sleep, increased irritability, possibly an elevated mood. And these are going to last for about 4 days. The depressive symptoms are going to last for longer, so a week to 2 weeks, and they're still going to be severe, but again, not as severe as in bipolar 1. And there's still an increased risk factor for self-harm. The last one we're going to talk about is cyclothymia. Cyclothymia is one that most people haven't heard of, or if they have, they don't know a whole lot about it. Cyclothymia is going to still experience those mood swings, so hypomania and depression, but there aren't enough symptoms to qualify it for bipolar 2. Also with cyclothymia, it's going to be rapid. So there's going to be a rapid change in mood swings. It's also going to last for an extended period of time. So for adults to be diagnosed with cyclothymia, they have to be experiencing this for 2 years. For adolescents or children to be diagnosed with cyclothymia, they need to be experiencing it for at least 1 year. And what's important to understand with cyclothymia is that there aren't extended periods of stability. So these rapid mood cyclings are just continuous.
Thank you, Mrs. Potts. This is Mrs. Eddy, and I'm going to continue our presentation talking about trauma. So trauma is defined as any experience that leaves a person feeling hopeless, helpless, or fearing for their life or survival, their safety. And this experience can be real or perceived. That's the most important part to me when we are looking at students, is their perception of what has happened. So we mostly think of trauma as our big T's, natural disasters, such as being displaced from something like Hurricane Harvey, physical or sexual abuse, combat or war, sudden loss of a loved one, sexual assault. These are all things that are people's lived experiences. And then we have our small t traumas that over time can lead to some diagnoses that we're going to cover in a bit. And these can look like bullying or teasing, over people pleasing, perfectionism, chronic or emotional neglect. And also many times people will be familiar, or students will come in saying that they have had reactions like a fight, flight, freeze, or fawn. And this happens when our body goes into safety mode. So for trauma, lots of times that's where it's stored, and a great resource for this is the Body Keeps Score. And it talks about how trauma is stored in your body. And that's why we have these big reactions to something that people might look at and go, wow, that doesn't really seem that scary or, that offensive. But when somebody has had a traumatic experience, they're going to feel it much more than somebody that hasn't had that same experience. So we normally say if it's if you're getting hysterical, it's historical, meaning something in your history has led you to this point. So trauma, many times people have suffered greatly, but in order for it to actually be a diagnosis in the DSM-5 for PTSD, we're looking for four main things. So PTSD is a mental health condition that occurs when a person directly experiences or has witnessed a traumatic event. So, what we're looking for is they're persistently re experiencing this event. They have avoidance symptoms. They don't want to go places that normally they had gone before the traumatic event. They're hyper arousal. They're hyper alert. Their cognition and their moods and their symptoms. 1 in 11 people will experience PTSD in their lifetime. So that's a pretty high percentage, and kind of the diagnosis is expanding. And I want to talk to you guys a little bit about that. So PTSD is related to a single event sometimes, or it can be more events, and it can be complex, which is prolonged over time or repeated trauma. Also, sometimes people can have a delayed response, but we think about all these things when we're making a diagnosis. Something new in the DSM-5 is children under 6 years old have now been included. And of course, their symptoms are going to look very much different. They might reenact their trauma through play. They might regress, like having bedwetting. So those are some different things that we'd look for in our younger children. This slide I want to show you next is really interesting because it kind of addresses that post-traumatic stress disorder really overlaps with a lot of other diagnoses. So I'm not going to go through all of these, but there are just so many commonalities. So regardless of, what a student comes to us with, it's always important that we're looking from a trauma lens and that we're really trying to take into consideration what's the perceived problem from the student's point of view. So next we're going to look at substance use disorders, and this has also expanded since the DSM-5 was put out, and it kind of includes more of a spectrum when we are looking at substance use. It also doesn't sound so pathological when people used to say addict or alcoholic. Now it's a substance use disorder, which again is on a spectrum. So most of our students don't actually qualify, wouldn't meet the criteria for having a substance use disorder. But the good news, and where I find lots of hope with my colleagues, is that they don't have to hit rock bottom or to get to a point where they do meet the criteria in order to be suffering some of the consequences or in order to be getting some help. So, of course, it's very common in high school age students to experiment with different substances. And anytime a student on campus is caught with an illegal substance such as marijuana or alcohol at school, they are mandated to have 3 drug counseling and alcohol sessions. So I'm going to talk to you in a minute kind of how we might have a session and some of the topics we might talk about, because of course lecturing doesn't work for many of our young people, and that's okay. So we really want to get more to the bottom of where the pain is, or what they're looking for, what need are they trying to fulfill when they're turning to substances. So like I said, we don't have to go all the way to hit the red button anymore, but we are, when we are diagnosing, we're kind of looking for a pathological pattern of behaviors related to whatever substance it is that somebody's using. So here are criteria for a substance use disorder, and you have to exhibit 2 or more of the following over a 12-month period. So you can read through this list, but I want to kind of focus on 4 different areas. One, we're looking for impaired control. So that would be drinking more often than not, and having it on a number of events and activities where they normally didn't have it before. Also, social impairment. People might not be able to go out socially unless they have a drink or a substance that they've had before going somewhere. So they're kind of using it as a crutch. And we may also see when it becomes the point where they have a substance use disorder, they just might not have any hobbies or activities that they're participating in, period, because they've come to rely so highly on the substance. So they might be staying in and not engaging in leisure. Risky use of the substance, that would be anything from driving or taking risks that they normally wouldn't take. So kind of that frontal lobe goes offline, and they're more impulsive, doing things that they wouldn't do, taking lots of risk. And then finally, the pharmacological impacts, which is tolerance, the ability to have more and more of the substance without consequences, and then withdrawal, which is when they don't have the substance, they're having some negative feedback from that and consequences, such as a hangover. So what's the good news, and kind of where do we fit in with this? Because like I said, most the students wouldn't qualify under this criteria. So prevention efforts and treatment approaches for addictions generally are as successful as those for other chronic diseases. So many times people will say, well, somebody's relapsed, or they've gone back, or they did the substance one time again. But we kind of like to say, well, they did, but that doesn't mean it's a total failure, because we don't know how much work they've gotten done to get to the point where they are. So we really want to look behind what their values are and if they're in line with what they want to be doing. So there's some different things that we're going to look at. First is, what pain are they experiencing? Are they, has something happened recently that they don't think they can deal with without the substance? Because of course we know that there's a numbing agent with many things, or that it kind of takes them out of contact with themselves. They're terrified of not belonging in different groups. This is especially where we see more of this risky behavior if they don't engage in partaking. Also, they're afraid they might be miserable without the substance, and they're maybe ashamed of what it means about them if they do fall into this category. And many times with teenagers, they come up with all different types of things, like, well, marijuana, it's natural, so it must be good for me. Or, I know somebody else that drinks or smokes all the time, and they're fine, they have a job. And again, they might, but they might also qualify as having a substance use disorder. But until we look at the person individually, we don't know that. So I really want to connect with the student and know if this substance is in conflict with any of their values. So for example, a lot of students might want to go work out at the plants, and they know for a fact, especially like if they're graduating and they're in the welding program, that they're going to get tested out at the plants. So that's something that they're like, I kind of want to cut this out before I go and work out at the plants, because they really value the idea of having a job after they graduate and they've worked hard. So we kind of look at something that's called cognitive dissonance. And I like to explain it as, you're coming in here, you're doing the substances still, but you're telling me that you want to go work out at the plants. So what we'll see is this kind of disconnect, this dissonance in between those two. And that's where we start to see a lot of the anxiety and depression showing up. So there's lots of values work that goes into substance use disorders. And we hope that that's part of the prevention, so that they don't fall into those patterns and get to a point where they're facing a diagnosis later on. We really appreciate you all taking your time to spend with us, And if you have any more questions, we have our information up here. Please feel free to reach out, and we would be happy to connect you if we don't have the answers. Have a good one.